I welcome you all respected doctors. Myself, Hussain Rawat, I am your host today for, for a webinar on very interesting topic, that is typhoid fever in the pandemic of COVID-19. Before starting the session, I would like to introduce our speakers for today. First of all, I want to introduce Dr. Mukhtar Ahmed. He is FCPS and working as an Associate Professor of Medicine at Allama Iqbal Medical College and Jinnah Hospital, Lahore. Our second speaker for today is Dr. Azad Ali Khan. He is also FCPS and working as an Assistant Professor of Medicine at King Edward Medical University, Lahore. And our third speaker for today is Dr. Muhammad Awais Abed. He is also FCPS in Medicine and Gastroenterology and working as Assistant Professor of Medicine at Services Hospital, Lahore. So, before starting the session, I would like to introduce our topic for today. That is, as we know that our main topic for today is typhoid fever. So we have three speakers today. First, Dr. Awais Abid will explain typhoid fever outbreak in Pakistan. He is also cover typhoid fever overview, and he also cover clinical presence of typhoid fever. Then Dr. Asad Ali Khan will discuss the diagnosis of typhoid fever in the current scenario, because there is also mixing with the COVID symptoms. So Dr. Asad will explain the diagnosis. Then Dr. Mukhtar Ahmed will discuss the current guidelines for the treatment of typhoid fever and latest studies for typhoid fever. So now I request Dr. Muhammad Awais Abed to please start your presentation. Thank you.
Assalamu alaikum ji. Hello and a very warm welcome to all the people who have joined this Zoom presentation. My topic of presentation for today is a brief discussion on enteric fever, typhoid fever that is, keeping in view the XDR typhoid that we've been experiencing recently. So I'll be mapping up with the first part of the presentation, that is the presence of typhoid fever, the XDR typhoid, the clinical symptoms, and obviously the diagnosis, and the later part would be covered by the other colleagues. I hope everyone is listening me. I hope my voice is reaching out to everyone. Is it so?
Yes,
okay,
sir.
Well, please just move on to the first slide. The typhoid fever outbreak in Pakistan. Now, this is interesting and this is important because the XDR typhoid, the multi-drug, the extensively drug-resistant typhoid fever that we've experienced over recently, the last year in Lahore as well. Now, it began in November 2016 in Pakistan when the health authorities reported an ongoing outbreak of extensively drug-resistant typhoid fever that began in the Hyderabad district of Sindh. An increasing trend of typhoid fever caused by antimicrobial resistant strains of Salmonella enterica serotyphi, or commonly known as S. typhi, poses a notable public health concern. From November 1 to December 2018, a total of 5274 cases of XDR typhoid were reported. That is a big percentage. That is approximately 60% of the total typhoid fever cases reported. Out of 8188 cases, 5274 were XDR typhoid. 69% of the cases were reported in Karachi, the capital city, and 27% were reported in Hyderabad district, and 4% were reported in the other districts of the province. As we see in this data, that most of the cases were reported in 2018. It began in 2016, where only 11 cases were reported, but in the year 2018, a total of 4,533 cases were reported. Now, the data, as it signifies, The 5274 cases that were reported, the majority were reported in Karachi, the capital city, and 1405 were reported in Hyderabad, and 211 were reported in the other districts of the Sindh province. And we move on, please. Yeah. This is the classification of the typhoid fever. It's classified conventionally rather into non-resistant typhoid, multi-drug resistant typhoid, and then the extensively drug-resistant typhoid, the outbreak that we've just experienced in the years 2016 to 18, and even in the year 2019 that we might experience now. The non-resistant typhoid fever is the one that is caused by Salmonella typhi or paratyphi, A, B, and C strains, which are sensitive to first-line drugs, and third-generation cephalosporins with or without resistance to second-line drugs. Now, those that are very conventionally treated with cephalosporins and third-generation cephalosporins or first-line agents are non-resistant typhoid fever. Then we come across another type, that is the multi-drug resistant typhoid fever, again caused by Salmonella typhi or paratyphi, and are resistant to the first-line recommended drugs of treatment, with or without resistance to second-line drugs. And then we move on to the extensively drug-resistant typhoid, known as the XDR, a typhoid caused by the Salmonella typhi strain, which are resistant to all the recommended antibiotics for typhoid fever. Next, please. Now, the antimicrobial resistant patterns to Salmonella that have emerged recently include a large amount of resistance to the drug ampicillin, which was conventionally used previously. 89.4% resistance is documented against the drug ampicillin. Another very old drug that was used is cotrimoxazole. 26.3% resistance has been documented to this drug as well. The resistance then declines further for the use of naldexic acid and chloramphenicol, whereas the resistance to cefixime and ceftriaxone is only 5.2%. So the drugs cefixime and ceftriaxones are the ones which are having the least resistance against the Salmonella isolates. Can we move on to the next slide, please? Now, this slide shows the global prevalence of the typhoid fever. Obviously, the presence of typhoid fever, especially in the third world countries, it's a fact because of our dietary habits and our inability to maintain the aseptic techniques. Enteric fever caused by Salmonella typhi or Salmonella paratyphi, A and B, and uncommonly the C strain, causes a disease that is clinically indistinguishable from typhoid fever, particularly in parts of Asia. There are an estimated of 11 to 21 million cases of typhoid fever, approximately 128,000 to 161,000 deaths annually, compared to an estimated 6 million cases of paratyphoid fever, which result in 54,000 deaths annually. The majority of the cases, as I said before, in the third world countries, that is South and Southeast Asia and the Sub-Saharan Africa. The typhoid overview. Now, what is the clinical presence of typhoid? What symptoms do people develop? And what is the incubation period of typhoid? Now, this is the topic that will be covered in this section. Typhoid fever is a systemic bacterial disease with insidious onset. Now, we've all known the symptoms of typhoid. It presents with headache, malaise, anorexia, relative bradycardia, splenomegaly, non-productive cough in the early stage of the illness. Although some texts state that rose spots are found on the trunk in 25% of white-skinned people, and constipation is seen more often than diarrhea in adults. Paratyphoid fever is an illness that occurs similarly, although spots are more frequent and brighter red than in typhoid, but usually less severe than typhoid. Complications are less common and typically arise in the third week of fever. Serover paratyphi B refers to the invasive biotype that is associated with paratyphoid fever, a variant referred to as Serover paratyphi B var. The mode and patterns of transmission. The mode of Salmonella typhi transmission is considered to be largely indirect and predominantly vehicle-borne, though contaminated water or food. Portal of entry of Salmonella typhi infection is the mouth, usually through ingestion of fecally contaminated water or food. Infection occurs in a susceptible host. The incubation period shortens, and the risk for infection and disease increases with the ingested dose. Gastric acid provides an important barrier to Salmonella typhi, accessing the small intestinal mucosa, in turn, the reticuloendothelial system. As we are learning with other diseases, that the barrier, the gastric acid, with all those PPIs that are currently in use, is obviously weakened, and so the host becomes more susceptible to an infection like typhoid fever. I'd request all the participants to please switch off their mics so that there's no barrier, there's no disruption in the transmission. Next slide, please. The onset of illness is insidious, with gradually increasing fatigue and a fever that increases daily from low grade to high grade. It may, increase up to 104 Fahrenheit by the third or the fourth day of illness. Fever usually takes time to subside, and sometimes it takes approximately even a month to subside. Fever is commonly lowest in the morning, peaking in the late afternoon and evening as the work routine progresses, and as the fatigue worsens, the fever also worsens with it. Headache, malaise, anorexia are nearly universal, and abdominal pain, diarrhea, or constipation are also common, but they're not experienced in every patient. Can we move on to the next slide, please? The clinical presentation elaborated further. Vomiting and diarrhea are common in children compared with adults. Children suffer more as compared to, malnourished with enteric fever as compared to the adults. People can also have fatigue, myalgias, dry cough, and a sore throat. Hepatosplenomegaly can often be detected. Most commonly, a large spleen is detected, a marginally large spleen. A transient maculopapular rash of rose-colored spots can occasionally be seen on the trunk. The clinical presentation is often confused with malaria, and typhoid fever should be suspected in a person with a history of travel to an endemic area who is not responding to anti-malarial medication. Now, it's still debatable that areas that are endemic to typhoid are also sometimes endemic to malaria. So if someone has had a visit to these areas, then obviously the clinical suspicion of malaria and typhoid both should be in there. Next slide, please. Untreated, the disease can last for a month, and reported case fatality ratios are 10 to 30%. Obviously, with this, generally after 2 to 3 weeks of illness, the life-threatening complications may include gastrointestinal hemorrhage, intestinal perforation, and sometimes the patient may also experience NCAF. Paratyphoid fever is usually described as less severe than typhoid fever. However, severe cases of paratyphi infection have also been reported from Asia. Can we move on to the next slide, please? The typhoid fever ranges 3 days to more than 60 days, depending on infective dose and some other factors as well. But typically the fever lasts from 8 to 14 days. The symptoms usually last from 8 to 14 days. After 14 days, we've seen some cases with low grade fevers like 99 or 99.6. But the diet, resolves completely. The constipation, diarrhea, the malaise, the headache, and the abdominal pain resolves completely. As compared to the paratyphoid infection, the incubation of Salmonella paratyphi is thought to be shorter than for typhoid, usually 1 to 10 days. However, surveillance data suggests that the incubation period for paratyphoid can be just as long as for typhoid. The inoculum size and the type of vehicle in which the organisms are ingested greatly influence both the incubation period and the attack rate. The infective dose of paratyphoid is higher than for typhoid fever. Next slide, please. Now, the infectious period. Infectious period lasts as long as the bacteria are present in the excreta, usually the first week of illness and throughout convalescence. Left untreated, about 10% of the typhoid fever patients will discharge Salmonella typhi for 3 months after the onset of symptoms, and 3 to 5% become chronic carriers. Now, these chronic carriers are the ones that carry the infection in their gallbladders, and sometimes cholecystectomy is the only treatment that is left. The chronic carrier state may occur with or without the case ever having an acute illness. So actually, the chronic carrier might not even know that he's a chronic carrier because he's never experienced symptoms of typhoid. There is less published literature for paratyphoid on the excretion of Salmonella paratyphi, but it appears that excretion is similar to most other Salmonella. Most people whilst a small minority, 5 to 6 weeks, whilst a small minority may continue excreting for months or even years. Prolonged biliary excretion applies in some cases, as in typhoid fever. Next, please.
Dr. Thank you very much, Dr. Asad Ali Khan. So please discuss your presentation about the diagnosis of typhoid fever in the current scenario of the pandemic of COVID-19. So Dr. Asad, please start your presentation.
Right. Thank you very much. Assalamu alaikum everyone, and a very good afternoon as well. Before I proceed with my talk, I would have a couple of quick questions. One to our host. Usually these presentations end up with a sumptuous lunch. So I was wondering, how are you going to serve today?
That's good.
That's great. That's great, Dr. Saab.
You've kept everybody on the lunch table and they're supposed to listen to us. So I'm wondering what is actually happening with these things. And thank you very much, Avas. You made my life very easy. You explained most of the things. So all I'm supposed to do now is just to share how we are going to diagnose these infections and what exactly is the correlation with the COVID. That is a part that we are going to discuss today. So if we can move on to the first slide, please. All of you can see there, most of the details are on your screen, but we are not going to start from here. What we are going to talk about is how important is Vidal and Typhoid or other antibodies dependent assays, which can really help us diagnose with the enteric fever things. The problem is most of our colleagues and in our medical field, most of the people are relying on these tests instead of going for the cultures. So before we proceed on to the cultures and their sensitivities and specificities, I think it's really important that we talk about Vidal and Typhoid. These are the tests that we normally do. Vidal, as we all know, has been kind of time tested, and it's been there for most part of the decades. But the test is not really sensitive as well as specific, although it can diagnose just a small percentage of these patients. But you cannot really be certain that the patient is actually carrying enteric fever if his or her Vidal is positive. Likewise, if you go for the antibody test, the typhoid, through the typhoid test, those IgMs and IgGs do give you an idea that the patient might be carrying enteric fever at the moment, but they're not really certain anyway. And we have seen so many cases where patients are having IgG positives and their IgMs are negative and they are still being diagnosed as enteric fever cases, being treated as well. They come back and they tell us, okay, we get typhoid every year. We have this thing, we do these courses every year, and we still cannot get rid of this. So you see, these Vidals and Typhoid are not really diagnostic, although they can help us diagnose these cases in areas where you cannot really have the blood cultures. But in our part of the world, we kind of rely on either Vidal or Typhoid to diagnose these cases, which is probably not the right approach to diagnose. So what can we actually do about these cases? You can go for the cultures. Now, usually we go for the blood cultures, and we kind of think if the blood culture is positive, we are going to treat the enteric fever, which is not exactly true again. It is positive in 40 to 80% of the cases, which is like a huge range if you talk about this, because 40% is at one end, 88% is at another extreme, and there's a huge gap in between, and then you miss quite a lot of cases again. So just the point is, if you get a blood culture positive, that is enteric fever. But if you get a negative blood culture, a sterile culture, that still does not rule out enteric fever. So in those cases, if your clinical suspicion is a very high thing and you actually believe that you are dealing with a case of enteric fever, please go ahead, start the empirical treatment and get rid of this. Or you can consider your differentials, and as soon as you have those labs back and you can formulate another diagnosis in place of enteric fever, fair enough. But relying on a blood culture is again not really necessary. A bone marrow culture, on the other hand, is an absolute beauty in the sense that it can diagnose up to 90% of the cases. I'll disagree with this 80%. It's 90%. But how many times have you gone for a bone marrow culture to diagnose a case of enteric fever? That is the big question. So although it is like a gold standard test for diagnosing enteric fever, but then the resources and how to go about the bone marrow culture thing, it's really difficult. Stool culture, again, is something very prevalent in our part of the world. Lots and lots of people go for the stool cultures, but it does not really yield a positive result in the first week. Although, if you get a stool culture done in the third week of the illness, which is like the really crucial part of the illness when you can get those GI hemorrhages and enteric perforations. So a positive stool culture can really help you diagnose and rule out other things at the same time. There is another thing, although they have mentioned about the urine culture, I'm not going to really consider that much. It has a lower diagnostic yield. Another really important thing is the intestinal aspirate. Now, if you get a duodenal aspirate, you get those intestinal secretions and you do a culture on that, it again proves whether or not the patient has the enteric fever. So now, if you have these three cultures, if you combine 1, 2, and 3, 1 is your blood culture, 2, a bone marrow culture, and 3, your intestinal aspirates from the duodenum. It's not that difficult. It's not invasive. You can do a duodenal string test and you can get those secretions. And then if these cultures are positive, then you can confirm the patient is a case of enteric fever. And if the question is, okay, what do we do in the meantime? If you do not have an alternate diagnosis, if your other differentials are not really sticking, then you can continue with the empirical treatment while you get the culture results back. So blood culture, in most cases, bone marrow, and duodenal aspirate. So these are the three cultures which can really help you understand and diagnose whether the patient is a case of enteric fever. Please move on to the next one. We were talking about differential diagnosis earlier while we were sending all those cultures and we were waiting for the labs to send us back the results. So what do you do in the meantime? Like everywhere else, we love to get a CBC on all those patients with the fevers, and anytime and every time a patient is presenting with the fever, we tend to rule out a case of hepatitis because we all love that raw गन्ने का रस type thing. मैं और अवैस मिलके जाके पीते होते थे एक वक्त था जब हम एक ही हॉस्पिटल में काम कर रहे थे, तो हर इमरजेंसी के बाद हमारा शौक होता था कि जाके हमने पी के आना है या लस्सी पीकर आते थे. So given those things, whenever these patients come back, and this is something which is not really unique to us. Everywhere in Lahore, at least, people are doing these kind of things all the time. So you tend to rule out hepatitis in all those cases. You tend to rule out other causes like malaria, like Avas was talking about malaria earlier. Then if we consider the weather these days, you don't know how many dengue patients we are dealing with at the moment. So that's a big debate for another day. We are not going to talk about that. But then you need to consider those differentials as well. So what happens in the enteric fevers? You get those leukopenias and neutropenias. That can get freely reported on CBC of many of these patients. The abscess of eosinophils is quite common, but we don't really look into the eosinophils much. And you can get all those tests done and might find something for dengue or malaria or other things. So much so when you're considering these differentials, you still need to consider an acute case of HIV as well. But anyway, common things happen commonly. So malaria, dengue, these are the common things, and hepatitis, of course, which is so prevalent in our society. You might get those transaminitis in these cases, but remember, a transaminitis does not necessarily mean that this is a case of acute hepatitis. However, you need to consider that while you are waiting for other results like the cultures, that this case might be a case of acute hepatitis. So you can get these leukopenias, neutropenias, or transaminitis in these cases. A thrombocytopenia can be there, not necessarily, but then that would more be in the favor of a dengue infection instead of enteric fever. Next slide, please. Again, we are dealing with those things. This wasn't supposed to be part of the differential diagnosis. I think Avas kind of took away a couple of my slides and left one for me in exchange. So this was more like the transmission of these enteric fever cases. You really get those fecal routes. Most of the time, people kind of talk about this as a traveler's diarrhea as well. However, that is reserved for cholera cases. But anytime you have traveled into another area and that is supposed to be endemic as well, you consider this. Most of the times we have poor hygiene or poor sanitation. You listen to so many reports every other day that there are sanitation problems in those areas in different societies in Lahore and other areas, or there are areas where water is not really pure and clear, and they're showing those reports on the media as well. So in these societies, in these areas, you can get those endemic settings, and you might be seeing a lot of cases of enteric fever in these societies. Next slide, please. Okay, now the business end of the talk. What actually is happening with the COVID? What is enteric fever in relation to the COVID pandemic, and what are we doing about it? Now, it's not exactly history of the COVID because it is still prevalent, so we cannot really say what happened in the past. It is still happening. It started in December, according to this slide, but no, we have other reports that say the first cases might have reported back in November, or some are speculating as early as October as well. So irrespective of the fact, as of now, we know the first documented case was in Wuhan, although there are some French reports that are talking about very early cases of COVID in as early as November. However, once it started to spread out, we saw a lot many cases, and WHO declared this as a public health emergency. And later in March, they said this is the pandemic, and that's when we started to look at a lot of COVID cases. However, we in the early phase we were in the denial. Although ever since then the cases have been increasing, and earlier today I had a question that what do you think about the pandemic status in Pakistan at the moment? So it isn't thought to be increasing, it is still increasing. So if anyone thinks that the cases are on the decline and they are like decreasing in our part of the world, frankly, they are probably mistaken. The cases are still on the rise, the cases are still very much prevalent. I don't think it's a fair statement to say that we have had herd immunity, not until we have the stats and evidence to support this claim. But maybe if I bend the rules and I take some liberties, I might say that herd immunity could have been reported in Pakistan if we had all the data and everything. Next slide, please. So we still have a lot of COVID cases who are not going for the reports, who are not going for the PCRs. They are asking us to be treated at home. We can give them the medicines, the injections and everything. They'll get it done at home. I'm sure many of you are facing the same things. So what happened during this COVID pandemic was really interesting. A lot of patients started to come in and they were carrying reports of Vidal and most of the times Typhoid. And not very surprisingly, most of these patients had a positive Typhoid and in some cases some Vidals as well. And they walked in, they were like, Doc, we have typhoid. And if you try and tell them, okay, your symptoms are not in the favor of enteric fever, you're probably carrying COVID, they'll be like, okay, here's the report, look at it and tell us, does this not say you have typhoid? And it becomes very difficult to confront with these patients, to argue with them and try and make them understand, okay, no, it's not typhoid. Because you see, it's human nature that you want to accept a lesser evil instead of the actual thing. So everyone is believing that they're carrying typhoid, and there was a report back in June where they talked about a rising incidence of enteric fever in Peshawar. However, back then even the respected Dr. Saud claimed as well that these are not really enteric fever cases. So trust me when I talk about this, these are not really enteric fevers. We all know now that COVID can present with GI symptoms, with those diarrheas and everything. So treating those cases or diagnosing those cases as cases of enteric fever was probably, I wouldn't really call it a mistake, but a misdiagnosis maybe. Next slide, please. Now, this is a very interesting slide in the sense that if you've been following the media reports, the international media reports, you would really say the most of the cases that they were really reporting were in the age bracket of 60 to 80. These are the cases who were presenting with these problems, and they had a very high mortality in the same age group as well. While on the other hand, if we look at the distribution in Pakistan, you can really see that we do not have many cases in this age bracket. However, we have a lot of cases in the young age group. Look, if this were a live session, we were taking those interactive questions and ideas and guesses. I would have thrown this question that if anyone can come up with an explanation for this, but we'll skip to the answer right away. Most of the times, we do not have a lot of people in this age bracket, especially above 70. So that is the reason that you do not have a lot of cases in the 80 plus or 70 to 80 age group. So trust me when I tell you this, these, if you look at the population in this age group and the ones who had this COVID infection, the graph might look a little different, but that is a different analysis. So most of the people in our part of the world had this infection, or they are cured or something, but most of us have had it somehow. Next slide, please. Now, you all know about the RNA viruses, how they have a very promiscuous range of hosts, not really sticking to one host or another. They're skipping from one to the other. You get so many theories every other day. It started from the bat or came from the snakes or this or that, blah, blah, blah. Anything and everything you can think of, it can jump onto those hosts and it can infect everyone. Now, the more important thing is, what is the spectrum of the disease? How does it present exactly? So you can have those common colds, sore throats, just a feeling of lassitude, lethargy, or you could really walk in with a low-grade fever and tell your doctor that I had this, I took a couple of Panadols, I got away with this, but now I'm really sick and worried. Do I have COVID, or what, I was actually carrying COVID? And they're like, okay, fine, you can go away, no problems, not until you report back with a high-grade fever or something. So that is a mild end of the disease. But if you talk about the serious complications, you can have those ARDS or something similar to SARS or MERS. But that's not the worry as such. You can really treat those things. More importantly, you can have those generalized pulmonary emboli. You can have those GI issues. There have been reports of pancreatitis as well. So just a few reports about arteriosplenectomy as well. So it has a wide array of diseases, of spectrums. You cannot really say anything these days. Every other day there are new reports emerging. They're talking about unusual presentations. So it's safe to say that our knowledge with respect to COVID is still evolving. It's still not done and dusted. You might have a case of meningitis very soon if you haven't seen one. You could have anything with the COVID at the moment. Next slide, please. Now, what really happens with the whole COVID infection is something of an enigma still. There were earlier reports of of a 4-day incubation period, and then they brought in the 2 weeks period for the isolation, that even if you're carrying this, you might walk away with it after a couple of weeks. But then they talked about an earlier presentation on day 1 as well, although there were reports and there were limitations of the investigations as well, that you cannot really diagnose on day 1, but there were serum markers that were elevated on day 1 of exposure. So safely speaking, if you have been exposed to a patient and you haven't had anything in the next 4 days, it is less likely that you will develop the clinical spectrum of COVID, but you still can, in those cases, it can go up to 14 days. And once it is there, it usually takes 2 weeks to clear out. That is a life cycle of the virus. But even the CDC and WHO definitions are changing every other day. And now they're talking about, initially they were talking about a 3-day convalescent period if you're febrile without any antipyretics. But now they're talking about a 24-hour period. So like we talked about earlier regarding the clinical presentations, even the pathologies, the mechanisms, the pathophysiologies, everything is changing every other day. For now, they say if you are afebrile for 24 hours without antipyretics or any other supportive medicines, then you're good to go. You can walk out of your isolation. You can investigate these cases on the grounds of those serum ferritins, D-dimers, CRPs, IL levels. You can get a PCR and even now the antibody test. That's not for me to discuss. Please move on to the next slide. We already talked about this. How can you present with the COVID infections? There's nothing new in this slide. We have already discussed most of these aspects along with the unusual presentations as well. Next slide, please. I think I'm done with my part and I'll hand it over back to the host. So Dr. Mukhtar can take it from here. Thank you very much for your patient listening. And
now we move to the Dr. Mukhtar Ahmed. Dr. Mukhtar Ahmed, please start your presentation and please discuss the management of typhoid fever with the current guidelines. Dr. Mukhtar.
Welcome to all. Assalamu alaikum to all. You can hear me clearly? Rawat?
Yes, Dr. Mukhtar. Okay. Yes.
Okay. I'm thankful to Dr. Avyas and Dr. Ali, who has covered their part very effectively and very elaborately. Now we are moved to the management of the typhoid fever. Let's move to first slide. Okay. Today, in this session, most of us are busy clinicians who are dealing with patients regularly. If I give you a scenario, kindly will you comment on that? If a patient who comes with a history of 5 days history of fever with no other symptoms, what is your first diagnosis which comes to your mind in these days? You can answer in chat or have the answer in your mind. A patient comes with a 5 days history of fever with no other symptoms. Yes. Most of us are thinking of same COVID, and very rightly so, because we are in amidst the epidemic, rather pandemic of COVID. So if we diagnose COVID or suspect COVID in this patient, we are very much right. But should we ignore other diagnoses which can be treated? Is all other infections gone? Similarly, typhoid, which was very common in this area, is it gone altogether? No, it is there. So we should be having a suspicion for other infection. COVID, no matter, should be our first diagnosis, but in our differential diagnosis, we must be thinking of some other infection which are treatable, like typhoid. So in any patient who comes with a history of 5-day history of fever without any other symptoms, we must consider as second differential diagnosis common things which can be treated like typhoid. And similarly, if in this case we are able to perform the blood culture or bone marrow culture and they become positive for the Salmonella typhi, obviously this is a confirmed case of typhoid then. And we then treat the patient, and if the patient is still shedding the Salmonella typhi in the stool even after 1 year of treatment, then it means patient has become the carrier of the typhoid. So this is the case scenario of the typhoid, which is suspected case, confirmed case, and then the carrier. Next, please. Like any other infection, we can't control the infection unless first we treat it and then we trace the subject contacts and treat them and diagnose them and isolate them. So in case of typhoid, what are the contacts? They may be co-travelers who have traveled and shared the edibles in the same bus or in the same train or in the same plane. These are not the one who are just traveling by sitting by your side. These are the one who shared something edible with you. And similarly, household contacts who have shared your bathroom or have shared your utensils, cooking utensils, and cooked for you, or who have eaten from your cooking, they may be your contacts. Similarly, sexual contacts or other contacts which may be a contaminated water source, which may be provided water to a large number of people and getting them infected, or there may be a typhoid Mary, a carrier, healthy carrier who is transmitting, doing a cooking job and transmitting disease to everyone. Next, please. Okay. And then there are a few drugs which are found very effective in these days for the treatment of typhoid. And these are ceftriaxone, ciprofloxacin, levofloxacin, azithromycin, and cefixime. Next, please. A study recently published in December 2019, it is an interesting study which compared the response of both clinical and microbiological responses of azithromycin and ciprofloxacin in uncomplicated Salmonella typhi infection. This study was basically carried out in UK, and volunteers were taken within an age group of 18 to 60 years. And it has two parts. Study A, which compared the effect of the ciprofloxacin and azithromycin in patients who were previously given vaccine for the typhoid, and then they were inoculated with the Salmonella. And study B, in which the naive patients were inoculated with Salmonella typhi. And this is conducted at the Clinical Center of Clinical Vaccinology and Tropical Medicine, Oxford, United Kingdom. Next, please. In this study, initially 235 volunteers registered, but 75 were excluded from before the start of the studies. And then the study was started with 160 candidates. Amongst them, 86 were treated with azithromycin and 74 were treated with ciprofloxacin. Amongst the azithromycin group, 34 were again excluded because they were not blood cultures positive for Salmonella typhi. And similarly, in the ciprofloxacin group, 45 were excluded. And then amongst the azithromycin group, amongst the 52 patients which were left, 32 were enrolled in the study A and 20 were enrolled in study B. And similarly, in the ciprofloxacin group, 18 were enrolled under the study A group, and rest of 11 patients were included in the study B group. These patients were admitted and they were treated with the respective drugs, and they were followed up with temperature charting and blood culture daily, and they were also followed up with their drug concentrations, both which were measured both intracellularly and extracellularly. Next, please. And when we come to the outcome First was the bacterial clearance that was demonstrated by the culture negativity of the patients. And you can see the red line, which is demonstrating the ciprofloxacin response, and blue line, which is azithromycin response. And you can see the 100% of the patient in red line, they achieved the bacterial clearance in around 24 hours. But the 100% of the patient, they attained bacterial clearance with azithromycin, and that took about 96 hours. That is a lot more time taken by the azithromycin group than the ciprofloxacin. Next. Another outcome was the comparison of the fever response, that how much time was required for the temperature was required for these drugs to settle down the temperature. And you can see that the similar better response, earlier response was seen in case of ciprofloxacin group, both in study A and study B, and then the azithromycin group. So temperature settling was also earlier with ciprofloxacin than azithromycin. Next, please.
आजम काइंडली आप अपना माइक ऑफ कर दें काइंडली आजम.
Okay, and here we come to the comparison of the MIC, that is this is a simple elaborate the written result which we have already talked about, that ciprofloxacin took earlier response in the both in the bacterial clearance as well as the settling down of the fever. Next, please. Okay, and similarly, it was because both intracellular and extracellular concentration of drugs were being checked out simultaneously, which later on showed that ciprofloxacin at a usual dose of 500 milligram BD attained both intra and extracellular concentration, which were above the required MIC level for the drug. But in the case of azithromycin, the MIC concentration within the cells were attained, but extracellular concentration were below that level with the regular dose of azithromycin, which was used. And that dose which was used was 500 milligram daily. Usual dose intracellular and states, but the azithromycin was able to achieve it intracellularly only. Next, please. Let us conclude at this time. Number one, we are living in an era of pandemic of COVID, and no matter COVID is very much common, but we must not ignore other infections which are treatable and which are very common, like typhoid. If undiagnosed, typhoid is potentially a treatable disease, but if left undiagnosed, it will enter into the stage of complication and will become fatal. So we should not ignore other infection in the era of COVID, number one. Number two, whenever we suspect typhoid, before starting antibiotics, set blood cultures essentially. And it's a must, because only then we can diagnose it, and only then we can have the problem of sensitivity and resistance, which can be later on clarified with other drugs. Number three, if in case of if we have diagnosed the case, patient with suspected a case with typhoid fever, we must start with the second line drugs, that these are quinolones, because resistance has been found with the first line drugs that include chlorothalidol, ampicillin, and cotrimoxazole. So start with empirically with a second line drug, that is a quinolone, unless the culture sensitivity comes back and we decide the medicine accordingly. And again, then if azithromycin, in my opinion, should be reserved for those patients who have developed extreme typhoid resistance only. This is, in conclusion, these are the 4 points which should be kept in mind according to today's discussion. Any